Today, I will be looking at a subject that is very, very important that you are going to find, you are going to see in your NCLEX. Either you like it or not, you prepare for it or not, you are going to see it in your NCLEX. And it has to do with fluid and electrolyte. I will talk about fluid very quickly. I believe it's an area that is so easy that you can cover. Fluid is very important. We have intracellular fluid that is about 70% of our body weight, and extracellular fluid that is about 30% of our body weight. In young adult, about 60% is made up of body fluid. Older adult, about 55%. While in infant, about 80% of the body weight is made up of body fluid. So when they are dehydrated, the prognosis is not good. You need to rehydrate them as soon as possible. And I want you to know that fluid and electrolyte is very important. The reason why I'm not going to major on fluid is because I know you can work on that. But on electrolyte, I'm going to start with potassium. Potassium is an electrolyte that the body cannot do without. What is the normal serum potassium range? The normal serum potassium ranges from 3.5 milliequivalent per liter to 5.0 milliequivalent per liter. Anytime they are out of that range, it could be life-threatening. They are so critical that need to be replaced as soon as possible. Let's start with low potassium level. Low serum potassium level is called hypokalemia. Hypokalemia. What are the causes of hypokalemia? I'm talking about serum potassium level that is below 3.5. When they get below 3.5 and it goes to 2.5, that becomes very critical. It is life-threatening. Something has to be done immediately. And that's why NCLEX is so particular about this. You have to know the causes of hypokalemia. What are the causes of hypokalemia? What are the causes? The causes of hypokalemia is what we want to look at very quickly. Number one, excessive usage of non-potassium sparing diuretics. Take, for example, Laxatives. If a patient is on Laxatives and the potassium level is not monitored, that is not too good. It can lead to hypokalemia. Number two is the excessive secretion of aldosterone or the excessive use of corticosteroid like prednisone, cortisol. If there is excessive use of that, it can lead to hypokalemia. Excessive secretion of aldosterone from the adrenal gland that leads to Cushing syndrome is another cause of hypokalemia. If patient is not eating food that have the correct proportion of potassium, like potassium, potato for potassium, tomato, avocado, spinach, if they are not eating all these things, banana, there's that tendency that their potassium level could be low. And that is very, very crucial. If their potassium level is low, something needs to be done. And apart from that, if a patient is having issue with, GI, and the GI is not able to absorb potassium, that could lead to low potassium level. If they're having kidney disease, they may have issue with reabsorption of potassium in the kidney. All these can lead to low potassium level. And as a result of that, as a nurse, we need to know the causes. In case you assess your patient and you draw the lab and you find out this patient is having low potassium, what are those assessment findings that you are going to see that they may likely ask in your exam? Number one, if somebody is having low potassium level, there's that tendency that the heart rate is going to be going into arrhythmia. You are going to see irregular heart rate. You are going to see weakness in the area of their pulses. The peripheral pulses is going to be weak. The respiration is going to be shallow because of the weakness of the skeletal muscles. Apart from that, the bowel sound is going to be hypoactive. And when you look at the neural system too, you're going to begin to see some signs. Signs like muscle cramp is very common with low potassium. And as a result of that, something needs to be done. Apart from that, when you look at some of the EKG changes, and these are some of the things they do bring in NCLEX, EKG changes with respect to hypokalemia. Some of the EKG changes you are going to see, I gave it as an acronym that will help you to really know some of these EKG changes. I call it sit up. Your potassium is going down. SITUP. And I represent the first S by ST depression, because everything is going to be going in the negative. It's either ST inverted or ST depression. And when you go to the T waves is going to be inverted T waves. Inverted T waves. Or at times it may be flat. You may see it flat. And when you now talk about HEP, you are talking about prominent U waves. Those are the three things you need to pay attention to. Prominent U waves. These are some of the EKG changes you are going to see in the reading. And as a result of that, you need to pay attention to the fact that this potassium needs to be supplemented. So what are the nursing interventions in the case of hypokalemia? What are the nursing interventions? Number one, for this patient, the potassium needs to be supplemented immediately. You can use oral supplement, and at the same time, you can go through the IV. But one thing you will not do, potassium cannot be given through IV push. Write it somewhere, note that. Potassium cannot be given IM. Potassium cannot be given subcutaneous. So the option we have is to give that potassium through IV, and it had to be infused slowly. Take, for example, you want to infuse potassium. You start with at least 5 to 10 milliequivalent in 1 hour. It must not exceed 20 milliequivalent for 1 hour, because they are very, very corrosive. They can heat up the vein. And as a result of that, we need to be very, very careful. Apart from supplementing the potassium, if that patient is on not potassium sparing diuretics like laxatives, you need to change it to adactone, that is potassium sparing. It is very, very important. And if they are on corticosteroid, you want to look for a way around that so that this patient can be able to retain some of their potassium. That's very, very crucial. And apart from that, if this patient is having issue with kidney problem, we have to look for a way through which we can supplement their potassium. It's very, very crucial. But let me quickly say this as part of the thing that you need to note when you are giving potassium through IV. Number one, you have to make sure that you shake it a little bit after it's being supplied from the pharmacist. Shake it a little bit before you give it to them. Don't give it to them IV push, like I said. Number three, it must be infused slowly. 5 to 10 milliequivalent an hour. It must not exceed 20 milliequivalent an hour. And apart from that, if you are infusing, you have to place this patient on a cardiac monitor. And you make sure the lab is drawn on a regular basis so that this patient will not go into hyperkalemia. Apart from that, you need to monitor the vein because it's very corrosive to vein, and because of phlebitis or infiltration. And in case you notice that you want to DC that potassium from that particular part and take it to other IV in the other hand, it is so crucial. If you can do all these things, you can be sure that you get rid of the question that comes in the area of hypokalemia. Now let's quickly talk about hyperkalemia. Hyperkalemia is so important because at the same time it's life-threatening, and we need to pay attention to it. Don't forget I made mention of the fact that normal serum potassium level is 3.5 milliequivalent per liter to 5.0 milliequivalent per liter. Anything above 5.0 is hyperkalemia. It's referred to hyperkalemia. And when it now gets to 6.57, that is critical and it is life-threatening. Something has to be done immediately to bring down the potassium to make it to come in between the normal serum potassium level. What are the causes of hyperkalemia? Number one thing that you pay attention to, that you can see as some of the causes of hyperkalemia, is when a patient is taking potassium-sparing diuretics like adactone, the potassium can suddenly go above the normal range. So when they are taking adactone, make sure you check the potassium level at regular interval so that the patient do not go into hyperkalemia. Apart from that, another thing that could cause hyperkalemia is when a patient is taking excessive supplement that has to do with potassium, or when they are giving them excessive, supplement that has potassium as ingredient, that can make them to easily go into hyperkalemia. You want to be careful with that. Or when there is adrenal insufficiency, like we have in Addison disease, when the adrenal gland is not producing, enough aldosterone to instruct the kidney to hold on to the sodium, and the sodium is let go, and potassium is on the increase. As a result of that, that patient can easily go into hyperkalemia. A patient that has problem with kidney disease too is prone to hyperkalemia because the kidney is not able to excrete potassium the way it's supposed to excrete it. As a result of that, there could be potassium buildup, and that patient will go to hyperkalemia. And apart from that, patient too can go into hyperkalemia as a result of acidosis, fast metabolism. As a result of that, patient can go into hyperkalemia. You want to pay attention to that. What are some of the things that you are going to see as a nurse when assessing patient that is already in the, hyperkalemia stage? Number one thing you are going to see is that you are going to see irregular heart rate. The heart rate is going to be irregular. You are going to see palpitation as a result of that, because of that hyperkalemia. You are going to discover that the reading is in arrhythmia because of hyperkalemia. So all the body system are going to be going in the negative direction. And it is very, very possible for you to notice the early sign. And part of the early sign is, you notice switching in the mouth, twitch in the mouth because of hyperkalemia. And if it's not well taken care of in a timely manner, it can degenerate to flaccid. You see weakness of the arm, weakness of the leg. And as a result of that, that patient can go into paralysis. The later state of that hyperkalemia. Patient can go into coma, they can become lethargic, can see confusion, and they can go into paralysis. And you don't want that. Apart from that, some other things that you are going to see is that you're going to notice EKG changes. Or before I go into that, you are going to see hyperactive bowel sound. The bowel sound is going to be hyperactive. And apart from that, some patients may go into diarrhea. These are some of the signs of hyperkalemia. They can go into nausea and vomiting. These are some of the signs of hyperkalemia. Please pay attention to that. You are going to see EKG changes. And the EKG changes you are going to see, I use, this acronym to be able to understand that. And you can write it down. Tall, flat, wide, projector. I know some of you use projector in your church. Just imagine that. Tall, flat, wide, projector. What are some of the EKG changes you are going to see with hyperkalemia? You start with tall. You are going to see tall T waves. They call it peaked. And apart from that, the flat one, you are going to see flat P waves. Flat P waves. And apart from that, apart from the flat T waves, you are going to notice that the QRS is so wide in hyperkalemia. Apart from that, you're going to see the PR. PR is going to be prolonged. These are some of the things that you are going to see with hyperkalemia. What are the interventions as a nurse that you are going to do? Immediately you notice that a patient is going into hyperkalemia or is already in hyperkalemia. Number one, if you are giving supplement or you are giving not potassium-sparing diuretics, you have to DC that. If the kidney is functioning well, you may have to switch to laxes to get rid of some of this potassium. And apart from that, if you notice a situation of hyperkalemia, that patient needs to be on a monitor. If the range is still within 5.5 to 6, you can give that patient Chiacylate. Chiacylate will work very fast, and make sure you serve it cold. It's going to help with the excretion of some of this potassium so that you can bring it back to normal. In case the kidney is not going fine, Chiacylate will be good. But in case it is too high, it's critically high, take that patient to dialysis so that they can get rid of some of this potassium. If it's not too high, laxes will do the job. It will bring it back to normal. That is if the kidney is functioning well. And apart from that, you can make use of hypertonic glucose with insulin. What this is going to do is that it's going to draw some of the potassium in the extracellular cell. It's going to take it intracellular. And with that, you are going to have the potassium, come back to the normal range. These are some of the ways through which you can bring the potassium level into normal. And I want to say this, that some of the things that you need to monitor is that when potassium is going too low, you need to monitor the digoxin level, because there is that tendency that anytime the potassium serum level is low, patient can go into digoxin toxicity. These are some of the information that is going to help you as you prepare for your next exam that has to do with fluid and electrolyte. I will continue from there some other time. I want you to be on the lookout every week. Check on my channel, Tips for NCLEX. You will have relevant information that can help you to pass your exam, most especially within 75 questions. I want you to do me a favor. If you are blessed, if you have gained some things from this YouTube channel today, make sure you like, please subscribe, and be ready to get the best out of your next exam. Thank you.